The American Medical Association, basically in 2008, in looking at many things that needed to occur in this country, recognized that 50 million uninsured individuals was unacceptable. We were looking at the rising costs of health care, which needed to be addressed. We recognized that our health outcomes in this country were very poor compared to comparable countries in Europe, and we knew that we had to do something to affect these things. And thus, the Affordable Care Act became the first step in changing healthcare delivery in this country, in allowing more people to have access to healthcare via health insurance, expanding Medicaid opportunities in our country, innovative delivery reforms that are underway as we speak, and methodology to improving health outcomes and quality in our country. This was an important first step, clearly not the last step, but a process that it will be ongoing and evolving over many years as we continue to improve the healthcare delivery system in our country and the health of all Americans. When we speak about Medicaid, we recognize that this is a very vulnerable population of individuals in our country. Many of these folks don't get the care they need until it's too late, and they end up with devastating illnesses and complications that in fact cost this country a lot of money, but even more importantly, their quality of life becomes very poor. Thus, it becomes something that the AMA feels very strongly about, that Medicaid expansion in the United States is necessary and it should be accomplished. Now, many of our states have done it, have expanded the Medicaid in their states, improving the access to health care. What we've got to make sure is that other states understand the need and we can get past the politics and get on to what really needs to happen in our country to get those folks covered. It's not an easy job. We understand the problems around Medicaid. The AMA feels strongly that Medicaid reform needs to take place, that we in fact need to look at ways of improving efficiency, decreasing the cost, and ultimately improving access for these patients. Medicare reform adds a whole nother layer to what is happening in our country. If one thinks back to 1997, at that time, something called the sustainable growth rate was introduced as the methodology for Medicare payment, not only to physicians, but other providers of health care. That formula is based on the GDP, not on the cost of delivering care in our country. Over the last 10 years, the costs and the expenses of delivering care have increased 20%, whereas the payment to physicians have remained basically flat. And you can understand, if you were operating a business, that this is not a viable situation for many practices throughout the country. This has destabilized, if you will, many practices, particularly smaller practices, or practices dealing with the elderly. Chronic medical management practices, such as diabetes and heart disease and rheumatological disorders. This formula is bad. It needs to go away. And in fact, last year, an amazing thing took place in Congress, a bicameral, bipartisan support for a repeal legislation. Energy and Commerce, Ways and Means, and Senate Finance all agreed on methodology to pay physicians for providing the care in a meaningful way, to allow physicians to then transition to new models of care, to improve efficiency, decrease the fragmentation in the delivery system, all for naught, when at the end of the day, the politicians couldn't do it, wouldn't do it. A political issue, something that, however, is fiscally irresponsible if Congress does not deal with it, because at the end of the day, access to health care for our seniors becomes the issue. Graduate medical education in our country is the linchpin, if you will, for getting doctors into practice. In our country, you have to have graduate medical education. Those are the years of internship, residency, and fellowship that you are required to complete before you can go into practice. Now, in this country, we now have more medical students, more medical schools, and more patients. but the number of graduate education slots is capped as it was in 1997. A big problem. Congress has got to deal with this in an innovative way. The Institute of Medicine report, which just came out, unfortunately and sadly did not deal with this in a meaningful way. It is reshuffling the deck, if you will, around graduate medical education and not actually funding GME programs. It is apparent that we are going to have to look at alternative mechanisms for funding graduate medical education, involving insurance companies, hospitals, hospital systems, other ways to get money into the system to provide this education. It's costly, but it's important in what it does for our country. Unlike many countries, it makes sure that the young men and women who've graduated from medical school, complete these training programs, are qualified and expert at what they do. It's good for American healthcare. The AMA has been advocating for folks with mental illness and mental disabilities and mental problems for many, many years, in addition to substance abuse issues, because they are all connected. This is an ongoing issue for us. If you think back over years, though, mental health issues became almost a stepchild, if you will, in the healthcare payment system. Mental health carve-outs, for example, in many insurance plans created a problem. In this day and age, it's very important that mental health and all health issues be bound closely together. You can't separate them. Mental health must be integrated into all forms of healthcare delivery in our country. Thus, we advocate at the national level. We advocated in the ACA, for example, to have this occur. We continue to push for this to be resolved in an appropriate fashion. It is happening, but we must continue to keep the pressure up. You can't separate mental health from physical health. Let me speak to you just briefly about some of the strategic issues the American Medical Association is undertaking at this time. For me, they're very important. Some years ago, we used to have lists of things to do, but today at the AMA, we have three major areas of focus. The first is improving health outcomes for our patients. The second is accelerating change in medical education. And the third is practice stability and physician satisfaction. Let me talk first about improving health outcomes and why the AMA, why physicians should be doing this. People say to me, well, we have the public health service, we've got the federal government, why the AMA? And my answer is, why not? These are our patients. They are daily in our emergency departments, in our offices, in our ORs, in our radiology suites. They are our patients. So we decided after a lengthy process to deal with two issues, prediabetes and hypertension. If you think about the implications downstream of hypertension, severe complications, heart attacks, strokes, kidney disease, the list goes on. Type 2 diabetes, moving on to diabetes, and all of the complications that come with that. In this country, we spend over $500 billion a year taking care of those illnesses. Not to speak of the issues around what they mean for the patients, the quality of life, how life is affected because of these illnesses. So we've taken these on full tilt, working with the YMCA on prediabetes, so we can keep folks in a care system loop that helps them get this under control before they become diabetic. And on the hypertension side, working with the Johns Hopkins group around what are the care models that we need to have in place to improve hypertension control. You know, there are 30 million people in this United States with health care with poorly controlled hypertension. Why is that? We know how to treat it. We know how to diagnose it. What's missing? What's the elixir that is missing to allow those patients to have better control of their blood pressure? We're learning from pilots now, both type 2 diabetes and hypertension. Stay tuned. Some very important information is going to come. Accelerating change in medical education. I was trained the Flexnerian way. 110 years. I'm not 110 years old, but the system of training is 110 years old. We've recognized now for many years, as have academics, medical school deans, that we had to do something about changing the way medical students are taught. Make it more efficient. Make it competency-based, not calendar-based. Allowing young men and women who come to medical school with the passion to feel immediately that they're on a course of great satisfaction in doing something that's worthwhile, and getting them ready and getting them out there and ready to take on the challenges of healthcare in the 21st century. And last but not least, physician satisfaction and model delivery changes, care changes in this country. You know, over the past year, as my president year, I listened to doctors talk about how difficult the practice of medicine had become, how dissatisfying and frustrating it had become. They wanted to see patients. They wanted to spend more time with patients. They wanted to spend less time with administrative burdens, less time filling in empty boxes in a computer screen, get rid of dysfunctional electronic health records that don't work, get rid of the administrative burdens that keep me from doing what I do best, which is being with the patient, talking to the patient, and caring for the patient. Let's do that in a better way. And so we've been partnering with the RAND Corporation to study practices and look at what's happening and why. And so this is an important area for physicians and their practices as we move into an area of time now where healthcare is changing. And it's important that our physicians know what's going on and how they can improve their practice sites to improve the care of the patients that they take care of.